The overall goals of treatment following an ACL tear are to avoid occurrences of instability where the knee buckles or gives way, and to prevent the bones from shifting. As mentioned earlier, an unstable and poorly aligned knee can lead to further injury and degeneration. There are two general approaches to treating an ACL injury. One approach is non-surgical, such as physical therapy, modifying activities, or using a knee brace. The other approach is surgical reconstruction of the torn ligament. Your doctor will discuss your options with you, taking into account your activity level, willingness or ability to modify activities, your age, general health, and other factors. Most people with a torn ACL who want to return to sporting or strenuous physical activities will require surgery. A torn ACL cannot just be stitched back together because it will not heal. Instead, the damaged ligament must be replaced with a graft along its entire length. Activity level is more important than age when considering ACL surgery. Other considerations include prior injuries and problems with the same knee, such as existing arthritis, whether you can or want to avoid high-risk activities, and how well you'll be able to follow a rehabilitation program of exercises following surgery. Restoring function and preventing instability after ACL reconstruction requires following a prescribed exercise program in the weeks or months before and after surgery. Following this rehabilitation program is as important as the surgery, since it increases coordination and muscle support. This reduces the risk of complications and permits return to work or sports as quickly and safely as possible. The program of exercises to be done before surgery is the foundation for a smooth and rapid recovery. The goal is to regain a full range of knee motion before surgery. When a knee is stiff, swollen, and without full range of motion at the time of surgery, regaining free motion after surgery is much more difficult. Your doctor will write a prescription if you need to visit a physical therapist to learn the required exercises. Most people do these exercises independently, at home. Ideally, the exercises will restore the ability to straighten out the leg fully, to avoid the risk of permanent stiffness after surgery. Patience and persistence are key. It can take 3 weeks or more from the time of injury to achieve a full range of motion. Your doctor may or may not wait until you have achieved a full range of motion before undertaking surgery. Reconstruction of a torn ACL requires using a graft, either from your own body or from a donor. A graft from your own body may be taken from the middle third of the patella tendon, the kneecap tendon, which includes a piece of bone where the tendon inserts at the patella and tibia, or from the hamstring tendons. Donor tissue comes from a cadaver. It is sterilized and specially treated to discourage your body from rejecting it and to minimize the risk of infection. The donor material may come from a patella tendon, a hamstring tendon, or from an Achilles tendon. Your options concerning graft materials are an important part of your discussion with your orthopedic surgeon. You may have a choice of anesthesia. You may be asleep throughout the procedure and not be aware of anything that is going on. Or you may receive drugs to keep you relaxed, along with an injection around your lower spinal canal to numb the lower half of your body. Either way, your doctors will pay close attention to your comfort. The specific procedure for reconstructing a torn ACL depends on many factors. These include the choice of graft material and the surgeon's preferred technique. However, all ACL reconstructions include the following basic steps. The surgeon makes several small incisions to harvest any needed graft material and to work deep inside the joint using thin tools and an arthroscope. The arthroscope is a pencil-thin tube equipped with a miniature camera lens and fiber optic light. The camera connects to a large video monitor which presents a magnified image. The surgeon gets a direct enlarged view inside the knee and can evaluate all the structures. To implant the graft material, the surgeon drills a narrow tunnel straight through the angled pathway of the natural ligament from the upper shin bone through the lower thigh bone. This allows the graft to be threaded into place and pulled taut. The surgeon then secures the two ends. Eventually, the bone tunnels will heal around the ends. Next, the surgical team moves the patient's leg around to test the tension and stability of the graft and the knee's range of motion. When the surgeon is satisfied with the reconstruction, the skin is closed and dressings are applied. You may go home the same day or the following day as directed by your surgeon. The most common complications of ACL reconstruction are recurrent instability due to graft failure, stiffness, and permanent numbness on the skin around the knee. A less common complication is chronic pain. Rare complications include infection and blood clot. Antibiotics are usually given to prevent infection.